Request Dr. Nitin Jagtap to please come on the dais. He is a consultant Department of Gastroenterology and Hepatology, Asian Institute of Gastroenterology, Hyderabad, India. He has, to his credit, various national and international publications, and he has received Asian Young Endoscopic Award from Korean Society of GI Endoscopy. He was selected for Young Leaders Academic Program, Melbourne, held jointly by University of Melbourne and Chinese University of Hong Kong, and so many other things. So, Dr. Jatin Jagtap, the floor is yours, please.
And thank you, AMA Prayagraj, for inviting me for this symposium. After medical management of obesity and what we call diabeticity, I will be discussing what are the endoscopic options that are available to treat obesity and also diabetes. So I have nothing to disclose, and whatever examples and metaphor I will be using are just for illustration purpose. I am not intended to demean any person, class or community. So definition and all these parts has been covered by sir in previous talk. But how this obesity has evolved over time, and this is not the problem of current era. It started way back when the agriculture revolution occurred. A person who, animal named Homo sapien, who started agriculture rather than hunting and gathering his own food. Over a period, there is an industrial revolution, IT revolution, and now what we have is AI that may again increase the prevalence of obesity. So what are the grades of obesity in clinical practice? What happens first, patient is utmost denial that he still feels that he is not obese, he is in denial. Second grade is acceptance with action or inaction. And third stage is rejection. Tere baap ka khata hu kya? What our aim as a doctor is to increase the number of people who are in the acceptance with action mode. And that may be a lifestyle alone, pharmacology alone, combination, endoscopy, surgery, anything. So what happens with obesity in routine clinical practice? This is 2020 article published in American Journal of Medicine, which has seen more than, sorry, I'm not able to see this. So what they have done, they classified all the patients with BMI, underweight, overweight and obese, and followed around 70,000 patients over next 3 years from their index. And out of this 27%, there is only less than 1% obese patients who either prescribed a medicine or underwent any bariatric procedure. So we are poor in diagnosing and treating obesity. Where is the place for endoscopic intervention? Now there are new medicines are coming, but there is a certain gap between two, lifestyle, pharmacology versus surgery, and this gap can be filled by less invasive procedures such as endoscopic therapies. There is huge burden of obesity, diabetes and other diabetes, obesity associated comorbidities such as NFLD, NASH. So where does it start from? We all know that it starts from insulin resistance. If there is overweight, or there are people who are not overweight or obese but still they have insulin resistance, so there is option of endoscopic restrictive procedures for patients who are in obesity range or who don't have obesity. They can be treated with metabolic therapies, and I will come to them one by one. So these are two types of therapies, either which target to the stomach, which are gastric endoscopic therapies, or which target in small bowel. So there are various intragastric balloons available which can be placed endoscopically, and there are now newer advances coming up which are just swallowable balloons which you can prescribe in your own OPD, and patient don't require to go through the endoscopy route. So this is the largest experience come from this Orbera balloon, and which has shown that at 12 months there is around 25% of total excess weight loss and around 11% total body weight loss. But this is complicated by early removal because of intolerance in 7% of patients. So this is the balloon I am talking about, which is a swallowable balloon. You can localize the balloon when it's passed into the stomach by electromagnetic localization and filled with nitrogen gas, and you can place 3 balloons over a period of 6 to 12 weeks. This can be done by any physician at his OP. So we've seen 2 types of balloon. First is fluid filled and second is gas filled, and this has shown that fluid filled balloon produces more weight loss compared to gas filled balloon or intervention. However, there is associated increased intolerance and early removal in fluid filled compared to gas. So to restrict the intolerance, we have this special balloon which is adjustable balloon. If the patient is intolerant to the procedure, we can just intolerant to the balloon, after placement we can just hook this catheter again and pull it back and remove some of the liquid. Or if patient is not achieved a plateau, then you can just go ahead and insert more fluid and increase the volume of the balloon. So in this multi-center RCT, you can show that at 32 weeks there is 15% weight loss, and clinical response is seen in 92% in patients with adjustable balloon. I am also doing this study at AIG, where we are studying use of this adjustable balloon for obese NFLD patients, and till date we have enrolled around 36 patients, and we could show that there is a decrease in steatosis and NASH activity scores on liver biopsy. So what happens with this balloon? Many of the patients who undergo non-adjustable balloon, after 3 to 4 months there is a plateau in weight loss, and if we adjust and increase the balloon volume, they can achieve more weight loss, and one person can go up to 900 ml of fluid into the balloon. Suppose patient don't want to undergo any endoscopy, so this is the option for those patients. This don't require any endoscopy, it's just a swallowable balloon with the catheter. You infuse liquid and just pluck out the catheter. You can place it without endoscopy. Just on ultrasound guided, you just localize that balloon has reached into the stomach. And this balloon subsequently, after 3 to 6 months, disintegrate on its own and passes up through the stool. So don't require any endoscopy. This is in the early stage. This registry had shown around 13% weight loss at 4 months. Few patients required removal either by surgically or endoscopically, but this is very small number compared to the large patients who underwent this procedure. Intragastric balloon has showed significant improvement in metabolic and histological improvement in patients with NFLD, and this can show that pre and post balloon placement, steatosis, ballooning, inflammation, NASH score, and even fibrosis has improved in the significant number of patients. Coming to the second part after intragastric balloon, this is the endoscopic sleeve gastroplasty, in which what we do, we go inside the stomach with the help of endoscopy and suturing device attached to the proximal end of the stomach, and from the antrum at the incisura we start marking with this APC probe to decide where to take sutures, and after taking this APC marking as a guide, we use this suturing device to suture stomach from inside, and we just do application into the stomach and reduce the gastric volume. One suture we can take around 6 to 8 bites. These are the bites, and similar to this we can repeat this procedure proximally towards the fundus, and subsequently we can achieve around 70% of gastric volume reduction. We can use a reinforcement suture after initial sutures. This is called endoscopic sleeve gastroplasty, and you can see in this animation there is a reduction in the gastric volume approximately of 70%. So this procedure has been evolved in last 3 decades, where initial safety, technical feasibility was studied, then sutures pattern defined, and now we are seeing various studies which is coming up with weight loss outcomes. This is what ultimately we achieve. We start from the incisura and come back towards the fundus, and eventually the sleeve is formed along the greater curvature. And this is grade 1 evidence, which is randomized control trial, multi-center in US, where around 300 patients were enrolled for endoscopic sleeve gastroplasty versus lifestyle modification and low calorie diet and physical activity. At 52 weeks, the percentage of excess body weight loss was the primary endpoint, and secondary endpoints were changes in the metabolic comorbidities. So these 200 patients were randomized, 85 underwent ESG and 124 were in the control arm. And at the end of 52 weeks, out of these 90 patients, 81 patients were still eligible to undergo endoscopic procedure. So what happens, those patients who underwent primary ESG has achieved significantly higher weight loss compared to lifestyle alone, and those patients who underwent crossover, they could achieve similar weight loss after 1 year of initial enrollment, and those patients who had a primary ESG also maintained the similar weight loss at 2 years. So what happens at the long term? So this study has shown long term data in 68 patients. Mean total body weight loss is around 16% at 5 years, and 90 to 61% of patients maintained at least 5 to 10% of total body weight loss at 5 years. How it compares with the surgery, and this study from the Spanish group has shown ESG has a lower total body weight loss as compared to the laparoscopic counterpart, but it required shorter hospital stay and lesser adverse event as compared to the surgical counterparts. In this meta-analysis also showed similar thing. There is a higher weight loss with surgical procedures as compared to endoscopic. There is an option to repeat this procedure because if the patient is failed to lose significant amount of weight loss. And in this patient, 7% of the total primary ESG patient underwent redo ESG, which is technically successful in all patients without increased adverse events. And after repeat ESG, there is 11 to 26% of weight loss in these patients. Is it also possible to undergo laparoscopic sleeve after ESG? But one should able to identify the orientation of these plications and location of anchors and sutures, and one should exclude these sutures from the staple line when the laparoscopic sleeve gastroplasty is planned. This is our study from Asian Institute Gastroenterology, where we studied the role of ESG in patients with obese NFLD, and there are various scores of NFLD has been reduced over a period of 12 years along with the significant weight loss at 12 years. There is another modification of ESG. What in this procedure done, apart from the regular ESG, the antral part, the muscles in the antral part has been cut using endoscopic approach. This is called bariatric endoscopic antral myotomy. And with this addition of with this additional step, it can be up to 17 to 18% of weight loss can be achieved at 2 months. So coming to the second part, which is the duodenal aspects or the malabsorptive aspects of endoscopic therapy. We all know that how the glucose metabolism is going. Initially we used to thought that pancreas is main driver, but now over a period we are realizing there is a significant amount of contribution has been done by duodenum and proximal bowel. So what happens, there is a delicate balance of incretin and anti-incretins, and if this balance is maintained, we stay in a high euglycemic state. But if this balance is not maintained, we develop insulin resistance, increased glucose levels, cholesterol levels, and can lead to obesity and also NFLD. So the insulin resistance is root cause of metabolic diseases, which includes everything, and this can be driven through the small bowel also. This is the rat experiment, which is compared to humans also, and it's showing that there is a disproportionately high GLP-1 as compared to euglycemics. This is study by Rubino et al., which has shown that there is a rapid improvement in diabetes after RYGB, and this improvement is within a days of surgery. And so what we can learn from that, this has shown by this experiment by David Cummins, a patient who is severely obese and diabetes, all their medicines were stopped to achieve hyperglycemia. Once the hyperglycemia has been achieved, they undergo RYGB. Once the RYGB is done, they were normal oral feeding for 2 weeks. So there is no contact of food and pancreatobiliary secretion for this much time here for 2 weeks. They all stayed in normal glycemic state. Then what did they do? They put a gastrostomist tube and they started feeding through the gastrostomist tube. So there is a contact of pancreatobiliary secretions and food in this rule limb. And all these patients developed hyperglycemia. After that, what they do? They again removed the gastrostomist tube and started oral feed, and they again achieve normoglycemia. So this proves that duodenal passage of the nutrients is associated with insulin sensitivity and may be independent of weight change. And this is the device which is called endobarrier, which can be placed in the duodenum, and it can act as similar to the rule limb of the RYGB, and it can reduce the decrease the contact of food and pancreatobiliary secretion. So the food will go through the barrier, and the pancreatobiliary juices will be outside the barrier. And this has shown that there is an improvement in fasting glucose and milder improvement in the weight also, but significant improvement in liver enzymes. There is another device is called duodenal mucosal resurfacing. I think this video is not playing. Anyway, what this procedure do is endoscopically we put a catheter into the duodenum and infuse hot saline through the balloon of that catheter and try to ablate the duodenal mucosa so that whatever enterochromatic cells are there, they burn out, and we assume that after healing there will be a healthy mucosa which will take control of the metabolic pathways. And this Revita study has shown that there is a durable metabolic response after this procedure, significant improvement in HbA1c, fasting glucose, HOMA-IR. Weight reduction is not that significant, around 2 to 3 kg weight loss only, with improvement in liver enzymes also. This is the same study has been repeated in other population in Europe and Brazil also, and showing similar effects. Duodenal mucosal resurfacing improves the glycemic and hepatic indices in patients with type 2 diabetes, which is again replicated by various other studies. It reduces hypoglycemia, improves hepatic steatosis, increases insulin sensitivity, and improve other metabolic parameters also. This is another device which is endoscopic recellularization by electroporation. What we have seen in previous slide is duodenal mucosal resurfacing using hot air as a ablative material. But what electroporation does, electroporation rather than causing cell death by inflammation, it causes cell death by apoptosis. So the other risk of such as bleeding, perforation and stricture formation after procedure has reduces. And in this is very limited data as of now. Recently shown in the DDW conference, which is Digestive Disease Week at USA. There is a around 2 centimeter ring, metal ring, which if it is in the contact with duodenum, it ablates the duodenal mucosa, and the whole procedure requires around 30 to 60 minutes in these patients. So this is with the duodenal resurfacing using electroporation method. And you can see there is a change in the duodenal mucosa after regeneration at around 3 weeks. So the mucosa which is prone for insulin resistance can be again normalized to insulin sensitive duodenal mucosa. There are various techniques to achieve DMR, that is mucosal resurfacing, which is one can be laser, radio frequency ablation, or what I shown is electroporation. Is it possible to do RYGB with endoscopy? We are already doing endoscopic gastrojejunostomy, and we need to exclude the proximal bowel from that. And this is being tried now, where a gastrojejunostomy can be created with the endoscopy, using using this special types of SAMs called lumen opposing metal stents, followed by endoscopic sleeve gastroplasty can be done in the remaining stomach, and the pylorus opening can be closed with this metal device. There is endoscopy can be used for the weight regain after bariatric surgery also. The people who regain weight after LSG can be treated with ESG. Dilated gastric pouch can be, again, ESG type of procedure can be done. And if there is a dilated gastrojejunal anastomosis, it can be reduced with the bar system. Metal stents can be used to treat post-operative leaks after the surgery. I am associated with this group called WealthCon and HealthCon. We have an initiative to reduce obesity burden in the healthcare professional. We aim to achieve BMI less than 24 and maintain in 2024. And this is very simple protocol. 3 meals per day, no snacks in between, 30 to 40 regular moderate degree exercise, no sugar, snacks, sweets, meals, and processed foods. Eat more protein, vegetables, and do once a week complete fasting. Why endobariatrics? Because it's safe, easy, effective, reversible, and it can be repeated if required also. There are pros, there are cons, but the pros and cons depends on which side you are. As I shown, we need to see the bigger picture. It's we as a doctor against obesity, and there is a role of endobariatrics in the multimodality approach for the integrated approach of obesity treatment. To learn more about this procedure and see live being performed by all these experts, I invite all of you for this conference in this month end at AIG Hospitals, Hyderabad. Thank you.
Thank you, Dr. Nitin Jagtap. It has been a very nice demonstration, and you have summarized what can be the future treatment of obesity. Thank you.